Hi everybody, welcome again to Dr Manny's YouTube Learn Shops. This is one that goes into cardiac surgery, and it's really an overview so that nurses understand what cardiac surgery is all about. I've tried to make it as simple and straightforward as possible. Any additional questions can be directed towards me if you choose to. Anyway, this is part one, which is the introduction. Covering in this are really just to give you some historical highlights, review cardiac anatomy and physiology, coronary artery disease and cardiac valve disease, because that's primarily what the surgery is for. When we look at the historical highlights of cardiac surgery, it was an amazing time. In 1893, Dr. Daniel Hale did the first pericardial repair as a consequence of a knife stab wound to a patient in the United States of America. Following which, 3 years later, Dr. Ludwig Renn in Germany did the first repair of a cardiac stab wound as well. Must have been traumatic era. In 1908, Dr. Frederick Trendelenburg, there's a famous name, Trendelenburg physician, the first pulmonary embolectomy done in Germany. In 1916, as we've discussed previously, there was a medical student by the name of J. McLean who discovered heparin accidentally while experimenting with liver solutions. In 1925, Mr. Sutar did the first mitral valvotomy in Great Britain. Surgeons were addressed as Mr. in Great Britain and affiliated Commonwealth countries rather than Doctor. In 1937, Dr. John Strider did the first ligation for patent ductus arteriosus in the United States of America. And in 1944, very famous surgeon, Dr. Alfred Blalock, did what was called the Blalock-Tuzik, in actual fact, Thomas operation in the United States of America for an infant with cyanotic heart disease, and it was very successful. Have a look at the congenital cardiac anomalies learn shop that I provide under Dr Manny Learn Shop. Very interesting. In 1945, Dr. Gross did the first tracheal vascular ring in Germany. In the 1940s, not specific time mentioned, Dr. Dwight Harkin, through the Second World War, which essentially was from about 1939 through to 1945, surgery with World War injured soldiers, which a lot of techniques were developed during that point in time for cardiac surgery. In 1947, Dr. Thomas Sellens did the first pulmonary valvotomy. In 1948, Dr. Charles Bailey, the first mitral valvotomy. In 1948, Dr. J. Gross, Johann Gross, again, did the first closure of an aorto pulmonary window in Germany. In 1952, Dr. John Lewis did an atrial septal defect repair using only hypothermia, done in the United States of America. However, it was in 1953 that the first successful cardiopulmonary bypass operation was done on an atrial septal defect repair by Dr. John Gibbon, who's very famous in cardiac surgical circles. In 1955, Dr. Melrose came up with the concept of cardioplegia in the United States of America, which you can review in the cardiopulmonary bypass section of this learn shop. In 1959, or I should say in 1958 first, Dr. Glenn came up with the first cavopulmonary anastomosis in the United States of America, and then that was followed in 1959 by Dr. John Senning, who did an atrial switch, dextrotransposition of the great arteries in Sweden. In 1960, Dr. Robert Goetz documented the first coronary artery bypass graft surgery in the United States of America. And in 1961, two famous surgeons and inventors, really, Dr. Starr and Dr. Edwards, came up with the concept of artificial valves, and they did the first mitral valve replacement in the United States of America. Then in 1961, Dr. Cartwright in the United States of America did aortic and mitral valve replacements as well. 1961, Dr. Morrow, subaortic ventriculomyotomy in the United States of America. In 1963, the first implanted left ventricular assist device was documented as a bridge to cardiac transplant, possibly. In 1964, Dr. Duran came up with the concept of now formaldehyde porcine xenografts in Great Britain and transplanted an aortic valve. In 1959, Dr. Mustard came up with a Mustard procedure, which is an atrial switch using a baffle for dextrotransposition of the great arteries. He was Canadian. In 1967, Dr. Ross, a different Dr. Ross, did an aortic valve replacement and pulmonary autograft. That was called the Ross procedure, which you can review in part 2 of this Learn Shop. In 1968, Dr. René Faval-Lauro did the first documented saphenous vein graft to the right coronary artery in the United States of America. Now let's briefly review, which we have done previously, the heart. The heart is basically a muscular organ located in the midline of the thoracic cavity, and essentially, as an adult, it's a pump beating at about 60 to 100 times per minute. It receives deoxygenated blood from the body, then recycles it in the lungs, and then resupplies it reoxygenated to the body. Now, the normal cardiac location is that the base is located in the second intercostal space, substernally, and the apex is located in the fifth intercostal space in the midclavicular line. And essentially, it's a pump. It has a few other functions that are very important, but essentially, it's a pump. If the heart stops, everything stops. Cardiac arrest. Now, the tissue layers of the heart consist of the epicardium, myocardium, and endocardium. And the epicardium can sometimes be called the pericardium. You have the visceral, serous pericardium, and the epicardium basically is a protective layer of capillaries, nerve fibers, and fat. The myocardium is the contractile element. It's muscular. The endocardium is the inner membranous surface, smooth membrane lining of the chambers, which is continuous actually with the circulatory system, the arteries and the veins. Now, the external cardiac features are the size, on average, the male 325 grams, the female 275 grams, and it's basically the size of an adult fist. When it comes to the pericardium, epicardium, this is a cover, a heart cover, which is fused to the diaphragm. And the visceral is the outer layer. There's a cavity that contains about 50 mils of pericardial fluid, and then you've got the inner layer, which is parietal. And essentially, the pericardium prevents excessive movement, excessive dilation of the heart filling, and prevents friction. It's moving all the time. It's beating, it's contracting. Now, external cardiac features also include the SVC, the superior vena cava, which returns blood from the upper portion of the body and head. This now goes to the right atrial appendage, which connects to the right atrium. This connects through the tricuspid valve to the right ventricle. And then blood is pumped to the PT, the pulmonary trunk, and to the lungs. It returns to the left side of the heart via the PV, the pulmonary veins, of which there are 4. This now allows blood to return to the left atrial appendage, the left atrium, which goes through the mitral valve into the left ventricle and then is pumped through the aortic valve into the AO, the ascending aorta. The IVC returns blood from the lower portion of the body back again to the right atrium. And it follows the pathway through the tricuspid valve, right ventricle, pulmonary artery, pulmonary veins, left atrium, left ventricle, through the aortic valve, into the aorta, and back to the systemic circulation. When we look at the coronary circulation, you have two main arteries. The right coronary artery, the RCA, which bifurcates into the posterior descending artery, sometimes referred to as the right marginal branch. But it goes posterior to the back of the heart, supplying primarily the left ventricle and the right ventricle. Then you have the left coronary artery. And the left coronary artery consists of primarily the left anterior descending and the circumflex branch, which goes around behind the heart, supplying the left ventricle and the right ventricle. You also have other branches, such as the diagonal branch or other marginal branches, which come off the LAD, left anterior descending, and the circumflex artery. And they migrate to the posterior portion of the heart, which primarily consists of left ventricle. Then you've got the venous circulation. And the venous circulation consists of the coronary sinus, which is the large section, the great cardiac vein, the middle and small cardiac veins. And essentially, after the heart has extracted a good portion of the oxygen out of its circulation, up to 90%, it returns deoxygenated blood back to the right atrium via the coronary sinus. As you can see, you've also got other veins, like the posterior cardiac vein, but essentially the great cardiac vein, small and middle cardiac veins, and the coronary sinus are posterior. And when we look at the cardiac chambers, this is nothing new for you. The heart essentially has four chambers: the right atrium, the left atrium, the right ventricle, the left ventricle. And the right side of the heart essentially receives deoxygenated blood from the superior vena cava, upper portion of the body and head, and inferior vena cava, lower portion of the body. The left atrium receives reoxygenated blood from the lungs via the pulmonary veins. It then goes to the left ventricle where it's pumped into the ascending aorta out into the systemic circulation. But there are four cardiac chambers: the right atrium, left atrium, right ventricle, left ventricle. The right atrium and right ventricle are separated by a valve called the tricuspid valve, and the left atrium and left ventricle are separated by a valve called the bicuspid valve or the mitral valve. The right ventricle is connected to the pulmonary artery, which has a pulmonic valve which allows blood to access the lungs. The left ventricle is in conjunction with the ascending aorta, which has an aortic valve which allows systemic blood to be pumped from the left ventricle, reoxygenated, the cardiac chambers. Now, in a little bit more detail, when we look at the right atrium, you have the superior vena cava and the inferior vena cava entering, and there's a eustachian valve, which is more important in the fetal circulation, and it guards the inferior vena cava. It doesn't really have a role in the adult circulation, but it did have in the fetal circulation. The muscle is essentially 1 to 2 millimeters thick, not that much. The SA node, sinoatrial node, is located epicardially, and then you have muscular bundles, the crista terminalis, which becomes important for congenital heart disease, which you can review in the Dr Manny Learn shops. The AV node, atrioventricular node, is located endocardially, as is the coronary sinus, and you can see the foramen ovale, the limbus, and the tricuspid valve is the inflow to the right ventricle. Then you've got the right ventricle. The right ventricle is connected to the right atrium under normal circumstances, and its placement is anteriorly, directly behind the sternum. It's crescent-shaped. Its muscle is thicker. It's about 4 to 5 millimeters thick, and the inflow is from the right atrium via the tricuspid valve, and there are trabeculae carnae as far as a tract goes. The tricuspid valve is located here. There are 4 papillary muscles and chordae tendineae. This is the outflow tract from the ventricle, and it consists of smooth muscle in the infundibulum. There's a conus arteriosus, and the pulmonary valve is located here in the outflow tract. Then you've got the left atrium. The left atrium receives reoxygenated blood from the lungs. The endocardium is smooth. The muscle is a little bit thicker than the right atrium, 3 to 4 times thicker, 3 to 4 millimeters. 4 veins enter here, 2 are superior and 2 are inferior. The atrial septum has the remnant fossa ovalis, which was important in the fetal circulation. There are bronchial veins that drain the bronchi that inflow here, and the mitral valve is the inflow tract to the left ventricle. Now, the left ventricle is posterior, as we already identified when we looked at the circulation being the circumflex coronary artery, the posterior vessel from the right coronary artery. This is cone-shaped, and the muscle is quite thick, 8 to 15 millimeters, and the apex is about 2 millimeters thick. It's the most vulnerable. The inflow is from the left atrium, and there is a mitral valve with trabeculae carnae. The mitral valve has got 2 papillary muscles and the chordae tendineae. The ventricular septum is both muscular and membranous, as you can review in the congenital cardiac anomalies when we look at ventricular septal defect. And there is a limbus marginalis. The outflow from the ventricle is to the aortic valve and into the ascending aorta. Well, believe it or not, the heart has got a skeleton. And it's a fibrous skeleton. And it consists of 4 rings of dense connective tissue that surround both the mitral and tricuspid atrioventricular canals, the aorta, and the pulmonary trunk. And it's important because it provides structure and support for the cardiac leaflets of all the valves, mitral, aortic, pulmonic, and tricuspid, as well as electrical isolation between the atria and the ventricles, and it makes sure there's only one pathway from the atria to the ventricles electrically, and it's through the atrioventricular node, the AV node. And that becomes important. Look at the ECG Learn shop that I provide when we look at now anomalous pathways, which can create atrial tachydysrhythmias and sometimes ventricular tachydysrhythmias. Now, the cardiac valves are actually attached to the fibrous skeleton by anterior and posterior annuli rings. The tricuspid valve, as we mentioned previously, is between the atria and the ventricles on the right side. It promotes forward blood flow. There are 3 leaflets, and they're attached to a fibrotic annulus and chordae tendineae to the leaflets. And there are 2 papillary muscles. The valve is approximately 10 centimeters squared, and it has 3 leaflets, the anterior, the septal, and the postal, or posterior. These are 3 fibroelastic leaflets that are thin and translucent. The tricuspid valve, as I said, there are 2 papillary muscles and about 20 to 30 chordae tendineae. Then you've got the bicuspid valve, as we know, the mitral valve. And this is also between the atria and the ventricles on the left side, and it promotes forward blood flow as well. There are 2 leaflets, and they're attached to fibrotic annuli, also chordae tendineae to the leaflets, and there are about 2 to 4 papillary muscles. This valve is about 5 centimetres squared. And it consists of 2 leaflets, the anterior and the postal or the posterior, and there are 2 fibroelastic leaflets. The mitral valve, as I said, it's got about 2 to 4 capillary muscles and about 20 to 30 chordae tendae. The aortic valve, which seems to be the most problematic as we get older, is the entrance to the aorta, and it promotes forward blood flow. There are 3 leaflets, and it's got an orifice of about 4 centimetres squared. It opens during systole when blood is ejected, and it closes during diastole to prevent backflow. The pulmonic valve, which typically isn't problematic in an adult unless you've got chronic lung disease or some sort of pulmonary problem, this is the entrance to the pulmonary artery, and it promotes forward blood flow. There are 3 leaflets, and the orifice is similar to the aortic valve, about 4 centimetres squared, and during systole it opens and allows blood to be injected to the lungs, and during diastole it prevents black flow to the right ventricle. Now, as mentioned previously, in relation to the fibrous skeleton, this is really important for cardiac conduction. Now, remember, the cardiac conduction system, which we discussed in the ECG Learn shop, is a network of specialised cardiac muscle cells that initiate and transmit synchronised electrical impulses from the sinoatrial node for the coordinated contractions of each cardiac cycle. Now, the fibrous skeleton protects this process as it provides electrical insulation at the atria and the ventricular junction, the AV node. Because look at the diagram. Where the AV node is, that is the only pathway under normal circumstances from the right atrium through to the ventricles. In other congenital cardiac anomalies, sometimes you can have the fibrous skeleton being problematic, which allows accessory pathways into the ventricles from the atria. And if you have cardiac dysrhythmias like atrial tachycardias, atrial fibrillation, atrial flutter, this can now result in potentially life-threatening cardiac tachydysrhythmias. And have a look. There's the AV node, and it's implanted into the fibrous skeleton between the atria and the ventricles. And this is the only pathway, the only wire, only part of the conduction wiring system that under normal circumstances is allowed to go from the atria through to the ventricles. When we look at other pathophysiology, which is important, especially in adults, we look at atherosclerosis. And with atherosclerosis, there's atherogenesis, and there are 5 main steps. You've got endothelial dysfunction, formation of fat or lipid or a fatty streak within the intima, which is the lining between the intima and the media. And this is where cholesterol deposits itself. And if it does that, then what ends up happening, the body says this is incorrect, this shouldn't be happening. There'll be a migration of leukocytes and smooth muscle cells into the vessel wall. And this causes an inflammatory reaction to occur. And as a consequence of that, foam cells develop, and eventually there's degradation of the extracellular matrix, which basically means it ruptures. And if the fatofibro material comes in contact with platelets, it activates the clotting cascade, and you may get a thrombus, which is potentially obstructive within the artery. Now, with coronary arteriosclerosis, this is essentially what will cause the acute coronary syndromes. And the pathophysiology results in unstable angina, non-ST segment elevation myocardial infarction, or ST segment elevation myocardial infarction. And an acute coronary syndrome is really a suspicion or confirmation of acute myocardial ischemia or myocardial death, necrosis, infarction. Non-ST segment elevation myocardial infarction is one, as I said. ST segment elevation myocardial infarction is another, and both result as a consequence of unstable angina, which basically is unstable angina pectoris, which means, from the Latin, a strangling sensation in the chest. And there are three types of acute coronary syndrome: unstable angina, non-STEMI, and STEMI. You can see here in the coronary angiogram, the left coronary artery is obstructed, the LAD, completely obstructed, 100%. Then you've got cardiac valve disease, and common causes of valve disease include rheumatic fever, which is still fairly common in other third world or developing countries, birth defects, congenital defects, degeneration over time, and infections. And this occurs when the heart's valves do not function correctly. And this can be caused by valve stenosis or valve insufficiency, regurgitation, or incompetence, whatever terminology that you choose to use. With mitral valve disease, the image is showing you mitral stenosis. But you can have incompetence, regurgitation, as well. With either incompetence or stenosis, there will be calcification of the valve and eventually fibrosis with annular dilation. There will be papillary muscle dysfunction as well as caudal tendonae dysfunction. And this can be both stenosis and regurgitation. Incompetence basically is a leaking mitral valve. Stenosis means it's difficult for the left atrium to eject blood into the left ventricle. But they can be combined. You can have mitral stenosis with mitral regurgitation. And consequently, with mitral valve disease, you'll end up with cardiomegaly. You'll end up with an enlarged left ventricle and probably an enlarged left atrium, which could result in biventricular failure eventually. When we look at aortic valve disease, and you can have stenosis and insufficiency as well. Now, aortic valve stenosis occurs when the aortic valve narrows and it doesn't open fully, which reduces stroke volume, cardiac output. With aortic insufficiency, also known as incompetence or regurgitation, this is when the aortic valve leaks and causes blood to flow in a reverse direction during diastole, from the aorta back into the left ventricle. Aortic regurgitation from the left ventricle, or from the aorta back into the left ventricle. Aortic stenosis, difficult for the left ventricle to eject its stroke volume into the ascending aorta. This also can result in cardiomegaly or left ventricular hypertrophy and left atrial hypertrophy, indicated by the arrows. But again, you can end up having aortic incompetence, and as a consequence of that, the aorta can dilate as well. Then you've got tricuspid valve disease, and this is typically not a problem in adults, but it could be. Tricuspid valve is typically related to congenital heart disease or congenital problems, but if you do have it, it can result in stenosis or incompetence of the valve leaflets again. And the most common etiology is rheumatic fever. And involvement also occurs with mitral and aortic valve involvement. So this can be affected, it can affect all. But basically, it's blood leaking back from the right ventricle into the right atrium. And this can result in right heart failure as well. With incompetence or stenosis, again there's calcification and fibrosis, annular dilation, papillary and caudal tendonae dysfunction. The The valve just isn't working properly. Remember, the purpose of a valve, any valve, is now to provide forward flow. Even your drinking water tap. The valve essentially shuts off when you don't want the water, and it turns on when you do want the water. If it's not working properly, it's leaking, dripping, drip, 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 drip. Or when you do turn it on, it may not be working and you don't get any water. Then you've got the pulmonic valve. And the pulmonary stenosis is when the narrowing of the valve and the cusps, and they become stiff or thick, which reduces blood flow to the pulmonary artery in the lungs. Now remember what your lungs do. Gas exchange. This is important. So typically, however, it does result in congenital heart disease defects and is rare in adults. But adults can have chronic lung disease such as emphysema, chronic bronchiolitis, bronchiectasis, and that can result in pulmonic valve and pulmonary artery disease. Now, let's conclude this Learn Shop and review. Can you name the 3 tissue layers of the heart? I think it's pretty straightforward. You've got the epicardium, the myocardium, and the endocardium. Epicardium, also known as pericardium. Name the external structures of the heart which are arrowed in the following diagram. Have a look. You've got 1, 2, 3, 4, 5, 6, 7, 8, 9 structures. They are the superior vena cava, the right atrial appendage, right ventricle. You've got the aorta, the pulmonary trunk, the pulmonary veins, the left atrial appendage, the left ventricle, and the inferior vena cava. Name and locate the 4 chambers of the heart. You've got 2 right chambers and 2 left chambers, and they are the right atrium and right ventricle, the left atrium and left ventricle. Can you identify and name the 4 cardiac valves? You've got the mitral valve, the tricuspid valve, the aortic valve, and the pulmonic valve. Have a look. Under normal circumstances, the aortic valve is in proximity of the sinuses of Valsalva, to which the coronary arteries are cojoined. Tricuspid valve, 3 leaflets, mitral valve, bicuspid, 2 leaflets, and the pulmonic and AV valve, smaller, with 3 leaflets each, or cusps. Then you've got which cardiac valve is diseased in the following diagrams. Have a look. Look at the arrows. You've got aortic valve regurgitation and aortic stenosis. Aortic stenosis, the valve isn't open. And aortic regurgitation, blood is coming back into the left ventricle via the ascending aorta. Okay, thanks. That's the end of this Learn Shop. So, if you found this of any benefit to you, please recommend it to your colleagues. Subscribe if you choose to, but most importantly, go to part 2 of understanding cardiac surgery for nurses. See you next time. Ciao.